patient with critical ischemia, so patients with very complex lesions will definitely show up more, and we need to do something to adequately treat these patients and give them hope, the patency rate to prevent restenosis, and of course, bring them to bone healing. The cardiologists made a good job in the past. IVOS clearly leads to better outcomes in coronary intervention in terms of reduction in cardiovascular death, reduction in target lesion revascularization, reduction in NMI, and reduction in stent thrombosis. So the question is, why we are not doing the same as peripheral specialists and bringing IVOS also into our routine? The problem is that we do not see everything. We do not see the reality of angio. On the left side, typical case example. What we see on angiography is a 30% stenosis. On the right side, we see the reality on this marker. It's a 75% stenosis. And I think that has impact for our therapy regimen, and of course also in terms of patency rate and freedom from target lesion revascularization for our patient. So we need to discuss how can we assess the reality much better. Another case example here, we might see a patent vessel in the TP trunk, but there's a severe dissection here. Deep dissection extending into the adventitia, and this won't stay patent in this patient with critical ischemia. And if we do not treat this dissection, we probably will face restenosis and loss of patency very soon in the CLI patient. And we learned in the past that dissections are very important, by the way. It is very challenging to identify dissection due to the small vessel size, especially in BTK vessels, because of overlapping bone, because of calcification, because of small vessel diameter. And we learned from many studies like the development trial, the impact deep trial, that dissections are a reality. But unfortunately, we are missing this. And this is something we need to address, because we know that especially dissections are on a high risk for restenosis and intervention rate. Typical case example, is it thrombus? Is it dissection? No, it's just recall. We did not do a good job here just with TOBA. Based on angio, we have flow, so we would probably leave it, but based on angio, based on IVOS, we probably not. So IVOS could help us in many ways to evaluate the vascular characteristics. It could help us to guide us for our peripheral intervention, what device should we use, what kind of technique should we use atherectomy, scoring device, thrombectomy. It can guide us if we need to place a stent. So much better information data than based on angiography analysis. And of course, on the other hand, we need to raise the question, do we have data for that? So is it just an hypothesis, or are there real data? And there are a lot of data now available for that. Here, for example, just published in Journal of Endovascular Therapy that the reference vessel diameter based on IVOS analysis was much more appropriate than on angio. So the risk on angio-based balloon diameter tubes is that we undersize the balloon and do not create enough lumen, do not create stable lumen, and this definitely influences the outcome of our revascularization. And we could prove this. We just published this here from our prestige trial, which was an IVOS-guided atherectomy plus DCB trial. It's a call-up adjudicated study. And on the right side, you see that the baseline reference vessel diameter based on angio was significantly lower than baseline reference vessel diameter based on IVOS in BTK vessels. 1.24 millimeter difference. And this has significant impact because it means that based on angio, we definitely would have chosen a too small balloon to create lumen. So that means we have a lot of possibilities to implement IVOS into our routine, either as pre-interventional diagnostic tool, inter-procedural guiding tool, or post-procedural optimization tool. It can guide us to choose the right technology, to treat the remaining issues, and to decide, do we need to stent because of the remaining dissection, for example. It is sometimes not very easy to assess and analyze IVUS, the pictures on peripheral embolization and peripheral interventions. Just to show you how it looks like on a normal IVUS, you see a plaque formation here, you see even the intima, you see the media, and you see the adventitia. You can measure the plaque burden, the maximum vessel diameter, the minimal lumen diameter, and the degree of stenosis. You can perform a morphology analysis, so a plaque characteristic analysis. On the left side, you see a typical example for fibropathy plaque. On the right side, you see a typical calcification plaque, and even a thrombus. And with this morphology information, you can choose to either use an atherectomy, a thrombectomy, or just a balloon or scoring device. In post-intervention, you can see what we have done. Yeah? You can see on the left side that there's a significant dissection, and the less FSA post-atherectomy. We know and learned that dissection, as already mentioned, is a risk factor for restenosis. You can see that the stent in the middle SFA, here in the middle picture, the SFA was adequately implanted. But on the right side, we could see that we, based on engine, choose a bad diameter stent. Definitely too small stent. Would have been better to rely on the diameter on IVUS to have chosen a larger stent. So this is a typical malapose stent, and IVUS told us the truth. Sorry, we choose the wrong stent. Another case example, just recently treated, long SFA occlusion in a young patient. Okay, we can visualize that, no problem. I so use the standard guide wire, penetrated the occlusion, did a balloon angioplasty, and on the right side you see a long dissection area from the offspring of the SFA till distal part. Okay, that's normal. So just for more information how severe the dissect is, I performed IVUS. You see not sufficient lumen, you see definitely dissection, restenosis. So I said, okay, let's implant a stent here. So I implanted a 100 millimeter stent here in the proximal SFA. On angio it looks nice. Good lumen, good flow. But this was the IVUS. And IVUS told me, okay, you did a bad job. You implanted the stent and said it's a good stent implantation. You see this malapose stent here. The stent was crushed. Restenosis at 50+%. So definitely not a good outcome. And that means that we could probably learn a lot for our mention by IVUS. Recently, Alan published in JIN 2022 a 150 patient randomized study, angiography alone versus IVUS plus angiography for femtop artery intervention. On the right side, you find his findings driven in part by appropriate sizing of DCB, and you found that based on IVUS analysis, much better freedom from binary restenosis outcome than just on angiography. So we're getting more and more proof that the combination of appropriate diagnostic approach using IVUS is helping us in terms of patency rate and prevent restenosis. And when we look especially on his decision pathway, on the right side, you can clearly see how helpful IVUS was during the intervention. The type of change in the treatment plan due to IVUS findings, you see that he, based on IVUS, changed a lot to his initial plan. It increased the treatment length and increased in treatment device size. So IVUS totally changed his decision how to treat appropriately lesions. And also, Eric Szymanski from the United States published recently at TCT 2021 that this patient improved significantly in terms of patency rate. 500,000 Medicare benefactors underwent lower extremity peripheral vascular intervention from 2016 to 2019. Around 63,000 of these patients were treated by IVUS guidance. And you could see that the major adverse limb events for the patients treated with IVUS guidance was significantly lower than the patients who were treated just by angiography. So we are getting more and more proof that IVUS guidance is helpful for our patients. And therefore, we recently decided to involve all the interventionalists to help us to create recommendations how to implement IVUS in our daily routine. So we organized an expert consensus with 27 global PhD experts which participated in this consensus document. You see them on the right side. And what we did is we asked them how helpful could IVUS be in the different setups, pre-interventional, inter-procedure, post-interventional. And we asked them to score different examples appropriate for specific indication, may be appropriate and rarely appropriate. And you can see here the expert consensus on these different parts of intervention, pre-intervention, inter-procedural, post-interventional, and the green one are the highest recommendation. And you see that all these very highly specific experts highly recommended to use IVUS in the different settings, pre-interventional, inter-procedural, or post-interventional optimization. And this then we divided for femipop revascularization. You see highly recommended in most of these interventional parts, and we asked them especially also for tibial revascularization. And even here, they recommended it much more to guide the therapy with IVUS. So IVUS is definitely helpful, especially for BTK interventions, for recall assessment, dissection assessment, or restenosis assessment. This was the first part of my presentation. The second part of my presentation is to show you a study called the dissection repair study to use the intact TAC device after vessel treatment with atherectomy and DCB angioplasty, which we recently published. The objective of this study was to explore the safety and efficacy of this combination therapy for patients with peripheral artery disease, stage 3 to 5, mild, moderate, severe calcification, and to see if this combination therapy improves the outcome of our patients. These are the devices which are used. The Phoenix atherectomy device in different sizes, SFA BTK, 1.8 to 2.4 millimeter, followed by DCB angioplasty, and then either by IVUS or no IVUS dissection assessment if we have a dissection implantation of the TAC device. Just to remind what a TAC is, the TAC endovascular system is an adenine cage which helps to seal dissection in SFA, orbital, or BTK vessels. Different sizes are available, a 6-French device for SFA lesions and a 4-French device for BTK lesions. For SFA, we use here either the large device, the 2.5 to 6 millimeter, or a very large diameter vessels, 4 to 8 millimeter. It's a precise delivery system, pin and pull system, running over an O35 guide wire. The length of the device is 135 centimeters. So this is a typical case example where we use IVUS guidance. So analyze the vessel, analyze where the lesions are. I don't want to bother you too much with this case here, but you can see how we do it. We assess where the lesions are, then perform atherectomy with the Phoenix device, in this case the 2.4 millimeter device with a deflecting tip option to divide eccentric lesion, concentric lesion with this device. And after DCB angioplasty, very good outcome based on angio, no dissection, no recoil, good flow in the BTK vessels, good outflow in the pedal arch, as you can see here. But unfortunately, we did then IVUS, and IVUS showed us that there are remaining dissections, and the study purpose was now then to detect these dissections with IVUS and then to implant one of these just shown dissection healing devices, the TAC device, to heal this dissection. You see here there's a remaining stenosis here in the distal SFA, and we are coming in a second here in an area which we did not see on angio, that there is a dissection. You see this flap here, yeah? And you see even that the flow is going behind this flap, so this is a high risk flap for rethrombosis, even with amputated therapy. So this part we then implanted the tap. And this is the idea of this dissection registry to analyze if this combination therapy helps to prevent restenosis. We included 26 patients. On the right side, you see the cumulative lesion length, which we treated in the SFA in the completed area, 188 millimeters, so quite long, all-comers patients, I must say, patients with calcification, non-mild, moderate, or severe, and we treated also 5 patients with total occlusion. You see the procedure characteristics on the left side. Of course, atherectomy based on the protocol was used in every patient. You see the DCB per lesion which was used. You see the analysis of the dissection types A, B, C, and you see the tag used. You mean 3 tags per patient, meaning we found dissection in every one of these patients based on the protocol with either angiography or iris. On the right side, you could see that we could seal every dissection with the tag device, so had a very good procedural success, meaning no remaining dissection after the combination therapy, atherectomy, DCB, plus optional tag implantation. Every dissection was sealed. The bailout stent rate for this 188 millimeter lesion length study was 0%, no stents were needed, only tags. This is absolutely in line with the already published COBA 3 study design. This is a tag-optimized balloon angioplasty study which analyzed the efficacy and safety of the tag device in patients, in 201 patients with either shorter lesions less than 150 millimeter or longer lesions with lesions longer than 150 and less than 250 millimeter published. And you can see on the right side, 98.8% of the dissection were completely resolved. Absolutely in line with our study. So it's a proof of the study, of the tag study which we already published. You see that also here no bailout stent was needed. Everything could be sealed and healed with the tag devices. Back to our study, in terms of patency analysis, you could see that we had a patency in this 188 millimeter lesion study of 84% after 12 months in these patients. And this is also in line with the COBA 3 study. In comparison, here you see the 12 months Kaplan-Meier patency COBA 3 outcome, which is absolutely the same. So another proof of this COBA 3 concept study in terms of lesion healing, dissection healing. Freedom from revascularization within our trial, you can see here, 12 months, 90%. I think quite impressive for 188 millimeter lesion trial. So only 2 reinterventions had to be done based on clinical symptoms within our cohort. And this is again absolutely in line with the published COBA 3 data. 12 months Kaplan-Meier freedom from CDTLR, 96.8% in the COBA 3 trial. In terms of freedom or improvement of Rutherford scale, you can see that depending on our patients improved, of course. In terms of safety analysis, there was nothing spectacular to be mentioned. So in conclusion, dissections are underdiagnosed, underestimated, and undertreated. And the reason is that we are not using an adequate diagnostic tool. Angiography is not helpful, as I showed you, to assess dissection after our intervention. To prevent dissections, a lesion preparation strategy with atherectomy improves technical and procedural success in comparison to a non-lesion preparation strategy. So clear favor for lesion strategy, preparation strategy using lesion preparation strategies like atherectomy to prevent dissection, recall, or even preparation. The efficacy is not different to a non-lesion preparation strategy because the number is too low. So the next step will be definitely to organize a prospective registry which definitely could answer efficacy more. There were no safety concerns for atherectomy, DCB, dissection, and healing strategy in our trial. So absolutely in line with the COBA 3 trial.
for this very nice presentation. My question is, do you recommend that we should have the IVUS as a routine in our cases, because we are not using this actually? The first case you showed that SFA dissection that you treated with a stent and the angiographic picture was very good. To me, I would stop like that. But you used the IVUS and you discovered something that